and we want people to be in the mood to take the gloves off and have a vigorous debate. And sometimes when you take the extremes of positions, you can get to truth a lot faster. So I thought we would start with a 7th inning stretch and a few jumping jacks, and then we'll start with the debate. So everybody stand up. Big stretch. Big stretch. One side, then the other side. A few jumping jacks. Let's see everybody move. There we go. All right, now we got the blood flowing. That's just the first start for a debate. The next thing we're going to do, so we're going to take two of the most heated topics. If we thought the topics we had before were heated, these are going to be, I think this comes to the crux of the issue. Everybody can say for sure that DCIS puts you at risk for having invasive cancer. But the answer. That is the first debate. Spirit of debate, often when people start an argument, they make things up. So we're going to start with each of the debaters making up a fun fact about the other person, just to start things off. And so we have two fantastic people who are going to be debating this issue. Jennifer Marti, who is a surgeon at Cornell, and who is actually quite passionate about the treatment of DCIS and looking for better alternatives, and she is going to take the stand that DCIS should not be called cancer. And we have Stephen Narod, our esteemed colleague, who has spent many years dredging the data, and he is convinced that DCIS should be called cancer. And they are both going to make their case. And the half an hour that follows, we're going to have some discussion about these issues, but importantly, we're going to come up with, so each minutes, and then we have this half an hour discussion. But during that discussion, what we want, of course, is to find where is the common ground and where is the opportunity to improve. All right, so without further ado, Jennifer, make your case.
Thank you. So fun fact about Dr. Narod, he refers to Canada as America's hat. Okay, so thank you for the invitation. I'm so happy to be here. I think this is a fantastic meeting, and what an honor to be invited to debate Dr. Narod. So I'm here to argue that ductal carcinoma in situ should not be called cancer. So I have no disclosures, no financial disclosures. I will disclose that I'm a breast surgeon, so I make money by operating on patients with DCIS, but I also witness firsthand the harm that comes by telling a patient with DCIS that she has cancer. So what are we going to talk about? DCIS does not meet the definition of cancer. Overdiagnosis occurs with screening. DCIS is closer to atypia than invasive cancer. Most DCIS will not progress to invasive cancer. Patients over 40 actually live longer if you have DCIS than patients without it. I'll show you the data. DCIS is not breast cancer, it's a risk factor for developing breast cancer. And most likely, patients can be closely monitored with active surveillance, and you can intervene when necessary. I like to call this delayed surgery. And it should be renamed to help reduce anxiety and overtreatment. So why is this so important in the name? Well, you see tweets like this. Had my first mammogram. I was diagnosed with DCIS, early stage breast cancer. Is it early stage breast cancer, or is it a marker for developing breast cancer? They caught it early. Did we? Or as Michael Baum from the UK would say, we caught it small. But don't worry, I'll have a double mastectomy. Is this an appropriate operation that we should be doing to patients with precancer? And then there's the plea. Go get some blood work done, get your skin examined, catch it early. Is this really accurate messaging? Are those head-to-toe body MRIs that CEOs get actually helpful? And so the reason why you see tweets like this is because this woman is operating on this definition, which is common and accepted. Cancer is a neoplastic disease, the natural course of which is fatal if you don't treat it. And this is what the woman in your office is hearing when you tell her that she has cancer. She's afraid that this is going to kill her. And then there's the laboratory definition. This is a 19th century definition. And it's how the cells look under the microscope. But the appearance under the microscope is not predictive of behavior. Not all cancer will act the same way. Otis Brawley calls this pathologic profiling. And so this is not a new or radical idea, but we're still always debating it. And the heterogeneity of cancer has been recognized for a long time, as far back as 1955, when Barney Kreil, one of the pioneers for lumpectomy, said, "In clinical practice, to say that a person has cancer gives as little information about the course of the disease as to say that he has an infection. There are dangerous infections that may be fatal, and there are harmless infections that may be self-limited. The same is true of cancers." And so you can understand this heterogeneity by thinking of the barnyard analogy, which many of you in the audience may be familiar with. So you can think of different cancers act in different ways. So we've got the birds. These cancers are happening so fast, they cause a symptom or death so quickly. Anaplastic thyroid cancer would be an example. We wish we could catch these early, but unfortunately we're just not good at it. And then there are the rabbits. These are slowly hopping along until at some point they cause a symptom or death. And we catch some of these. We could be a little better at it. And then there are the turtles. These are moving so slowly, or maybe not even moving at all, that they never cause a symptom or death during the patient's lifetime. And the patient dies with it, not of it, and they die of other causes. These are overdiagnosed, and no symptoms or deaths are prevented by treatment. And so we do see overdiagnosis with DCIS, which is now a disease mainly of screening mammography. So with the use of screening mammography, the incidence has gone way up. It used to be 3% of cancers, now it's 20 to 25%, 50,000 women a year. And you may say, well, that's good. That's the whole point of a screening mammogram, to catch it early. Well, if we're really catching these early, and they were all destined to become invasive cancer, the incidence of invasive cancer should be going down, but it's not. It's gone up. And unfortunately, we don't have an impact on the incidence of distant disease. Not all DCIS will progress to invasive cancer, and many of these cases are overdiagnosed. So, do we have any data that we're tapping into a large reservoir of subclinical disease? So if you look at autopsy data, 1 in 10 women die with DCIS, not of it. And if you looked at the breast even more intensely, you'd probably find that number is even more common. And so DCIS does not meet the clinical definition of cancer. And I would argue that it doesn't meet the laboratory definition of cancer either, because cancer is invasive. I mean, is there any other kind? It's almost redundant to say invasive cancer. And DCIS is not. The cells are confined within the duct lumen, and they're surrounded by the basement membrane, and not all DCIS will progress to invasive cancer. So what is the natural history of DCIS if left untreated? So if you